Good morning, everyone. Sorry for the
Good morning.
okay. Share my screen. Okay. Uh, guys can see the screen. Is that right?
Yes.
Great. Just sit here. 1, 2, 3. So I think we're missing. Is it Perna we're missing? No, Perna's there. Sergey's here. Neha, Uzo. I guess we got pretty much everybody. Okay. Good morning. So we're going to go over an EP study we did recently. So this is the baseline ECG of the patient. The story is that this patient had a left-sided accessory pathway, WPW, and had prior unsuccessful, well, it was acutely successful ablations to ablate this pathway, but the pathway had recurred, and the patient had quite a bit of tachycardia, which was not recognized by the patient, interestingly, probably because the heart rates in tachycardia were in the range of about 140. And I think that in retrospect, the patient had a lot of, just had it for so long, didn't even recognize what was abnormal. So you can see that the patient is pre-excited. Uh, it's not very pre-excited, so the pattern is difficult to ascertain from just the surface electrocardiogram. Okay, so during catheter placement, the patient had SVT. And this is an example of the SVT. So, David, what do you think is, if you saw this as the patient's SVT, tell me what you see and what you think about it. And it's hard for you to tell what the heart rate is. I will tell you the heart rate in this tachycardia is about 150, just as an FYI.
What's the age of the patient?
Patient is 17.
Mm-hmm. So in terms of this SVT and kind of trying to think about the mechanism, I feel like in lead 3, I can see what looks like to be possible P waves that are superimposed on the T wave.
Yeah.
And it looks like, the RP interval there, it looks to be a little bit on the longer side. So some sort of maybe ORT kind of mechanism.
That's exactly right. So again, just remember that if the R to P interval is greater than 70 milliseconds, generally we think more along the lines of a pathway-mediated, accessory pathway-mediated tachycardia, such as orthodromic reentrant tachycardia, as you said. What else could this be? So that you're absolutely right. That is the most common and most likely thing. Anything else that this could be?
I guess a ANRT. No, I don't think it'd be as likely.
I mean, AVNRT, is that what
AVNRT, yeah.
Well, what kind of AVNRT might this be?
Well, it is narrow. It's a narrow complex.
How long is the RP interval typically in AVNRT?
I believe it's shorter.
Right, usually less than 70 milliseconds. So this is a little unusual, right, for AVNRT. But is there any form of AVNRT where the RP interval could be longer?
Is atypical?
Yeah,
The
atypical. That's exactly right. Atypical AVNRT can have. Remember that in normal AVNRT, we go down the slow pathway and we come back up the fast pathway, right? And so the P wave, retrograde P wave, can actually even precede the onset of the QRS. Because remember that in AVNRT, the reentry is occurring above the level of the His-Purkinje system. And so it might be that the retrograde A not only has a short RP interval, it could even be negative. It could even precede the onset of the QRS. So the fact that but if you had atypical AVNRT, you could have a long AV time and a long VA time. You can have, basically what they sometimes call slow or AVNRT. So this could be AVNRT, atypical. Anything else this might be? The heart rate's about 150.
There's, I guess, flutter could be another possibility.
This could be some kind of atrial flutter, and it's a reentrant atrial arrhythmia. Absolutely.
And then maybe a junctional rhythm, possibly.
Could be, although people talk about junctional tachycardias in people who haven't had open heart surgery. I be honest in saying I'm not sure I believe in that diagnosis. I think that most of the time those are just AVNRTs. And then finally, it could be a primary atrial tach, right? It could be an EAT, right? An ectopic atrial tachycardia. So, but in this case, some kind of reentrant tachycardia, and the presumption at this point is that it is from the accessory pathway. Let's move on to the next slide here. Now, this is actually a tachycardia during catheter placement. And I will remind you, so we only have one catheter in place at this point, which is the coronary sinus catheter going from proximal to distal. And why don't I ask Grace Kong if you have any thoughts about whether, based on what David was saying, this is the same tachycardia. Do you think that you have any greater insight into what this might be?
Mm-hmm. It does look like it's earliest in the distal coronary sinus.
Well, I would disagree with that.
Okay.
So this is the QRS, right?
Mm-hmm.
And so anything that's simultaneous with the QRS is going to be a ventricular electrogram.
Mm-hmm.
Anything afterwards is going to be A. So this is the V, and these are the A's. So I think in the distal CS, as you said, I think this CS pair, this A is kind of late.
Oh, that's the, okay.
Okay.
Got it.
But I think if you look here in 5-6, you could argue that this onset is pretty early, or at least is earlier. Let's put it this way. It's earlier than the proximal coronary sinus.
Mm-hmm.
It's also earlier than the distal coronary sinus. So it's
Mm-hmm.
somewhere in the area of 5-6 or 7-8, right?
Mm-hmm.
They're sort of similar in time. And I will tell you, just out of interest's sake, that because the patient had a history of having a left lateral to anterolateral pathway, an attempt was made to put the coronary sinus catheter out very far. And so this is actually the proximal coronary sinus in this particular case is actually really in the left posterior region. It's not near the mouth of the coronary sinus. So this is all very lateral stuff. And so this is further evidence that the tachycardia that the patient is having is due to a left-sided pathway. Now, the interesting question is, why is the tachycardia rate only about 150? My suspicion is that the pathway doesn't conduct terribly well retrograde. And that may be because that's just the sort of the natural quality of this particular patient's pathway. But it might also be that the patient, because of the prior ablation attempts, injury to the pathway may have been sustained, which is causing it to conduct less well. All right. And so tachycardia is reinduced, and the cycle length is 450. So Grace, what is the heart rate if the cycle length is 450? Just as a little math test.
So 60,000 divided by 450 is around 130.
Yep, 133 beats per minute. So tachycardia rate not very fast. But another thing you have to remember is it may be slower simply because the patient is under general anesthesia. So all conduction is going to be a little slower. Okay. Now, the patient is V-paced here. Actually, that's not true. This patient is just an SVT, so forget about that. Sorry. Okay. So we start rapid atrial pacing, and we're pacing from the coronary sinus pair, which is why you see sort of a sharp signal on the CS. Now, in this case, at this point in the case, we have not put in a high RA catheter or a His catheter because it seems pretty clear that the pathway is left-sided And a number of years ago, we wrote a paper showing that for left-sided pathways, it wasn't always necessary to have a His catheter. And so at this point, we tried to proceed without a His. Why are we rapid atrial pacing, Grace? Why do we rapid atrial pace during a WPW case?
You want to determine the refractory periods.
Well, why don't we get more basic? What am I trying to figure out about the pathway?
When you do, maybe not, you can figure out if there is a decremental characteristic to the AV node that you see.
No, what we're trying to do is figure out whether the patient is at risk for sudden cardiac death, right? So,
Oh, yes.
so how does rapid atrial pacing tell us if somebody is at risk for sudden cardiac death?
If you know their accessory pathway conducts above the heart rate of, I forget what the heart rate is, Dr. Pass, above a certain heart rate.
Say 250 beats per minute.
250. Then they're more at risk for sudden cardiac death. That's
correct. So what we're doing here, what Josie is doing is she's pacing the atrium faster and faster. So here we are at cycle length 400, which I remind you is a heart rate of 150. And we see still that there is this eccentric pattern in the coronary sinus where 7, 8, and 5, 6 are clearly beating the proximal and distal coronary sinus. Also, you can look on the surface ECG and see that we're very wide. So we're still conducting through the accessory pathway at cycle length 400. But now we come down. Josie's pacing a little faster, 380. And then we see at 370, something changes. So Sergey, what do you think has happened here?
We're not conducting through the accessory pathway anymore.
That's correct. So we see here that as opposed to this wide QRS, which is due to very significant degree of pre-excitation, we now have a narrow QRS, suggesting that we have exceeded the ability of the pathway to conduct at, in this case, cycle length 370. So this is would not be considered a high-risk pathway in terms of pre-excited, rapidly conducted atrial fibrillation based on the so-called Sperry, or the shortest pre-excited RR interval. So the Sperry would be 370, or actually I guess 380. Below that, it does not conduct. Okay, so that was important information at the start of a procedure, because we know that at least if we are left with the WPW, the patient is at least not at risk for sudden cardiac death. So that's a positive. Okay. All right, so now we start doing atrial extrastimulus testing. So here we are at 600, 350. We see that we're still pre-excited. And then 600, 340, something happens. So why don't I go back to Sergey. Sergey, what do you think happens here when we went 600, 340? And I'll point, this is where the 600, the 340, the premature atrial impulse has been put in at 340.
So the VA interval changed.
Mm-hmm. So what are we doing here? Are we pre-excited on these beats?
Yes, we are.
And then when we go 600, 340, what happens?
Yeah, I guess we'll lose the pre-excitation again.
Right, so what will we call this when we lose pre-excitation?
It's the refractory period?
That's right. That's correct. That is the accessory pathway effective refractory period. Okay. So again, 600, 340 is the accessory pathway ERP. That would not be consistent with high risk. It would be a low risk pathway. And not only do we block in the pathway, but we now start having tachycardia again. Okay, so this is SVT. Notice how narrow all these QRSs are compared to the surfaces, to the previous ones when we're apaced. And we again see that retrograde P wave that David was referring to before. Okay. So based on all of these data, we realized that the patient still had a left-sided pathway. And so we did a Brockenbrow transseptal to get into the left atrium. And I'll remind you that there are basically two approaches to ablating left-sided pathways. The one that's more commonly used amongst pediatric cardiologists is to go transseptal and do a Brockenbrow. But there are still quite a few electrophysiologists who would generally do these retrograde, placing a catheter in the femoral artery, going over the aortic, over the aorta, across the aortic valve, and then retroflexing the catheter back across the mitral annulus and mapping in that fashion. And most of the literature would suggest that that approach is similarly efficacious to doing it transseptally. But I think the reason that this is falling out of favor, the retrograde approach, is simply because of increasing degrees of expertise in transseptal puncture. And it has always been my impression that you can be slightly more precise in regards to moving the catheter around the annulus, but I know that people who do this routinely retrograde would not agree with that statement and would say they're perfectly well able to map around the annulus. And the literature would suggest they are correct, because the success rates are almost identical. Anyway, now we're in the left atrium, and we decided that we were going to do this in ventricular paced rhythm. We could map this in multiple ways. We could map in sinus rhythm, mapping for the earliest ventricular electrogram. We could map in tachycardia, looking for the earliest retrograde atrial electrogram. Why don't I ask Neha, what would be the disadvantage of mapping and ablating in tachycardia, do you think? What would be the benefits and what would be the downside?
I think benefit would be that when we ablate it, we lose the tachycardia as we lose the pathway. However, I think catheter stability is difficult while we are
Why is catheter stability difficult?
I think just from the heart rate and I think just from the heart rate being faster, it's difficult to maintain same position.
Yes, I think you're right. I think, though, the big issue is not that much getting the position in tachycardia, though you are certainly right. I think in general, it's probably harder to stay in the same place when the heart's beating very fast. But the real concern is that when the tachycardia terminates, in other words, if you are in the correct location and you successfully ablate the pathway, the heart rate will change quite suddenly from a very fast rate, in this case, a rate of 135, to a sinus rate at, I don't know, let's make a number up, 60. And so that often will cause the catheter to jump or move. The other advantage of doing it in tachycardia is when you're in ORT, you're going down the AV node, and the only manner in which you're going retrograde from ventricle to atrium is via the accessory pathway. That means that the retrograde conduction is purely up the pathway, meaning any map, any retrograde AUC is going to, you can feel confident, is not a combination of conduction through the pathway as well as through the AV node. Does that make sense? Like if you pace the ventricle, you theoretically could be going up the pathway, but also up the AV node, and you may be seeing some fused conduction between the two.
Right.
But in this case, we elected to do it in V-paced rhythm. The reason being that the patient was not very pre-excited. And I thought that it was easier to see the retrograde atrial electrograms than it was to see the antegrade ventricular electrograms. And I wanted it to be as easy for Josie and our tech from Carto, Kelvin, to be able to see the retrograde A's more clearly, because the the more easy it is. So Josie and Kelvin were using this atrial electrogram. So again, we're pacing the V. So these are all ventricle electrograms followed by atrial electrograms. And basically this was a very, very constant and consistent retrograde A. And for that reason, I thought this would be a nice way of mapping, because every beat, it looked exactly the same, meaning that the map would be very accurate, because it would be very easy to see the onset of the atrial electrogram in every single paced beat. And so what you see here on the distal ablation, I'm sorry, I clipped it by accident. You'll see that this is the ventricle signal and this is the atrial signal, and the retrograde A at the location of the ablation catheter was 16 milliseconds earlier than the earliest retrograde atrial electrogram in the coronary sinus. And that was the earliest site that we could identify in ventricular paced rhythm.
Dr. Bass, sorry, but how did you know that this is not through the AV node? Just because of the way it looked consistently?
So the first thing to say is there is possibility that it is fusion between the pathway and the AV node. But the reason that we thought this was going mostly up the pathway was because coronary sinus 5-6 was much earlier than coronary sinus proximal or distal. You see how these two beats, these two A's, are earlier than the A in proximal or the A in distal. So in other words, the conduction retrograde was eccentric, meaning up a pathway rather than concentric. If it had been going up the AV node, we would have anticipated that the proximal coronary sinus electrogram would have preceded the onset of the A in 7-8 and 5-6. Does that make sense, Neha?
Yeah, it does. Thank you.
Yeah, so that's how we knew it was doing that. But you are correct in asking the question, because it's certainly possible that what we're seeing here is up the pathway, but that it is not as pure up the pathway as if we were in actual ORT itself. So, you know, sometimes you make the decision that because of the benefits of catheter stability, because of the benefits of hemodynamic stability, sometimes you put someone in tachycardia and they don't really like it very much hemodynamically. And because of the ease of mapping, I accepted the fact that this might be partially fused, because all the other benefits of stability, catheter not moving, a nice clean map, I thought all of these outweighed the potential negatives. So here we are in V-paced rhythm. We turn radio frequency energy on, and Neha, what happens here between these beats and these beats?
So after the RF on, just in the next beat, you sort of have a clear, your pathway conduction changes. I think it becomes concentric. Concentric.
Right.
So we ablated the pathway correctly.
Right, and you can also see on the ablation catheter, notice how the V and the A are very close together here. And then once the pathway has been ablated, the V and the A interval have lengthened quite substantially. So, so because this patient this was now patient's third or more attempted ablating this, a large series of irrigated applications were placed at this location. I'll remind you that when we use an irrigated ablation catheter, we typically are able to make somewhat larger and deeper radiofrequency catheter ablation lesions. Most of the time for SVT, that is in fact not necessary. It may in fact not have been necessary in this case, but because the patient had had multiple attempts in the past, the decision was made to be more aggressive about making larger and deeper lesions. Okay, so now we are following ablation, and we see here again that we have this very long RP interval. So we're feeling pretty good about ourselves at this stage. However, when we are pacing the atrium, what do we see here, Neha?
When you're pacing the atrium, you see.
What does the surface look like?
Again, widened, excited.
Right. So, and where is the earliest? So now this is the A, right? A, I put a His catheter in. So A, His, V.
And
And you notice that the V's in the coronary sinus are actually earlier
then
than
the
the His and the V, right?
mhm.
So that means that the pathway antegrade or either the pathway we just ablated, we have ablated retrograde but not antegrade, or there is a second pathway that conducts only antegrade near the pathway we just ablated. It's almost impossible to know the difference. Some electrophysiologists would call this two pathways, meaning because we just showed, right, that when we pace the V, the VA time is very long now. We don't have any more ventricular-atrial conduction through the pathway. And yet, when we pace the atrium, we do have atrioventricular conduction through the pathway. Now, we know from our rapid atrial pacing that this is not a high-risk pathway. So one could argue that since the pathway is gone retrograde, that you could leave this. But given that this was a third attempt, we decided we didn't want to leave anything behind. So here we are at 500, 330, and you see even now more pre-excited where the ventricular electrogram is way ahead of the onset of the His. Normally the His V would be the earliest with atrial pacing. And then what happens is that at 500, 320, we block in the accessory pathway. So look here, this is 500, 330. And you see here how the ventricular electrogram in the coronary sinus is preceding the ventricular electrogram in the His catheter. But when we go to 320, all of a sudden the AV interval massively lengthens. And we now see that the earliest V is in the His, and that the V in the coronary sinus is later. And so what that means is that the accessory pathway ERP is 500, 330. And interestingly, this begins tachycardia. So the question then is, well, what is this tachycardia? Because we just showed that the accessory pathway cannot conduct retrograde. And so what we see, first of all, is that in tachycardia, if we draw a line at the earliest A, it's clearly in the His catheter. And all of the coronary sinus A's are later than the His. And there's no eccentricity here, meaning that the proximal CS is earlier, and as we go out further, they're later and later. So this is odd, right? Because we definitely have a left-sided accessory pathway that conducts antegrade, albeit weakly. But we've induced a tachycardia where the earliest retrograde A is actually in the His. And so this started us wondering if this patient had some form of either a right-sided pathway or maybe some kind of AVNRT. Now, David Barris, this R to P interval is about 150 milliseconds. So if this was AVNRT, would this be typical or atypical AVNRT?
Atypical.
That's correct. So the only way to explain this tachycardia would be to say that it's either some kind of a pathway on the right side of the heart, or that the patient is a very unlucky person in that they have WPW on the left side of the heart, but they also have AVNRT. And so the manner in which we figure out if this is AVNRT, I'll remind you, is that we place a PVC during a period when the His bundle is refractory. And why do we do that? I'll remind you again that we do that because at the time that if we are in AVNRT and there is no accessory pathway, if I pace, remember that in AVNRT, all of the reentry is occurring above the level of the His. So if I pace the ventricle at precisely the moment that the His has fired, that means that the His will be refractory, which means that when I try to go from ventricle to atrium, I must go through the His. But because the His is refractory, the ventricular paste complex should not affect what's going on in the atrium at all, because the His is refractory and disallows ventriculoatrial conduction. Okay, so what we want to see is, first of all, so this paste ventricular complex that Josie puts in here is falling precisely at the moment that the His bundle has fired. So what we want to know is the interval between this retrograde A and this retrograde A the same as between this retrograde A and this retrograde A? See, if there was an accessory pathway on the right side of the heart, it wouldn't matter that the His is refractory, because if I pace the ventricle early, it will go up the accessory pathway early, and the next A will be early. If, however, there is no accessory pathway, and this is AVNRT, when I put a His refractory PVC in, the next day should be exactly on time, because I cannot retime or reset the atrial contraction, because all of the reentry is occurring above the level of the refractory His. So the key question is this A to A interval the same as this A to A interval? And in fact, it is exactly the same. The His to His interval was 431 milliseconds, and this A to A interval is also 431 milliseconds, meaning that a His refractory PVC did not advance the next day. And that would be consistent with a diagnosis of AVNRT, or atypical AVNRT. Another clue to the fact that this is AVNRT is that the R to R interval was changing by about 10 milliseconds. That is what we sometimes refer to as cycle length oscillation, or a slight change in the R to R interval. That is much more common in AVNRT than in ORT. So those two facts made this seem very likely to be AVNRT and an atypical form. So now we have pre-excitation in the left atrium from this pathway, which is no longer conducting retrograde, and we have atypical AVNRT. So Uzo, your catheter's in the left atrium. You now have identified two potential issues. What are you going to do now? What would you recommend that we do? I see Uzo.
You said my catheter is now in the left atrium? No, right. I'm here, Dr. Paz. I am here. My network is fine.
Maybe it's one of your cell phone issues. I'm sorry. Yeah.
No, Dr. Paz, it's perfectly fine.
Excellent. So you must be using Barris's computer, but anyway, so you now have a catheter still in the left atrium. You have pre-excitation on a left-sided pathway, albeit a low-risk pathway. It does not conduct retrograde, and you have atypical AVNRT. And this is now your third time in the cath lab with this poor young person.
So I mean, I guess we already did a transseptal, so we're already in the left atrium. So, and this is the third time. You don't want to leave anything behind, so you might as well do both the ablation of the left-sided accessory pathway, and then come back and then try to map and ablate the
AVNRT.
like the AVNRT.
Well, see, having been around you long enough has very
yeah,
strong
go ahead.
influence on us, and that is exactly what we did, Dr. Obiaka. And so what we did was we decided to map the pre-excitation. Now, again, the hard part of the reason that we decided to ablate the pre-excitation is we don't really know if this is a second pathway that happens to be in the left side of the heart, or if this is a slanty pathway where the atrial insertion and the ventricular insertion are far from one another, meaning that you can ablate it retrograde in a different location than you can antegrade. So always hard to say. In this particular case, I feel bad, I forgot to take a picture of the CARTO map. It really did appear as if they were not in the same location. They were, in fact, the CARTO representative was able to demonstrate that when the catheter is at the location that it is in this picture. It was roughly 1 centimeter or 10 millimeters from the area where we successfully ablated a pathway retrograde. So I'm not 100% sure, but if I were a betting man, I would actually say that this is 2 pathways. And in fact, the prior reports reference the likelihood of it being 2 pathways as well. So in this case, the earliest we could find a signal was on time with the earliest coronary sinus pair. And so we go on with energy, with ablation, and you see that basically by the 4th beat, in a little under 2.2 seconds, we see that the AV time lengthens, and the pre-excitation goes away. Notice the difference in the delta waves here versus in this beat here. And so a series of RF applications, again using irrigation because of the 3rd attempt, and the patient also is much larger at this point. So we ablated this pathway, and because we were, and this is what the intracardiac look like now, we see here that the AV interval is much wider, and that the ventricular electrogram in the His is now earlier than the ventricular electrogram in the coronary sinus. So at this stage, we decided, since this was a patient's 3rd attempt, that we would put a few insurance applications in and also watch and wait, because once we come out of the left atrium, it's a bit of a pain to go back in. Pathway did not recover, and in fact, we gave IV adenosine and saw complete AV block, showing that there was no pathway, and ventriculoatrial block as well. But we could still induce AVNRT. You see here, this is ventricular extrastimulus testing, and we see a very long VA interval with the earliest retrograde A in the His pairs. But here again, with ventricular extrastimulus testing, you see that we've induced AVNRT again, where the earliest retrograde A is in the His. And again, this is an atypical form of AVNRT. Now, oftentimes atypical AVNRTs are a little more difficult to ablate than typical AVNRTs. So we're getting a little nervous at this point because we had already spent quite a bit of time in the left atrium. But we were very lucky in that when we, here is the AVNRT. Again, I'm just demonstrating here that in tachycardia, the earliest retrograde A is in the His and is earlier than all of the coronary sinus pairs. You remember when we were in ORT that the coronary sinus pairs were earlier, were very early. And so we put the catheter in the lowest third of Koch's triangle. And when we're doing a radio frequency slow pathway modification, we typically are looking for a small A and a fairly large V. This is a little different than what we're doing when we do a cryoablation of AVNRT. And as soon as we turn on RF, or a few beats into RF, we see that the patient starts to have a junctional acceleration. And that is often considered a good sign that you're in the right place. And so, as some of you may know, we generally in our lab don't like to sit in junctional acceleration without pacing the atrium, because we want to confirm that there is atrioventricular conduction at all times when we're burning near the AV node. So we stop RF transiently, we start apacing the patient, and here we are, Josie's pacing the atrium, and we see there's a nice consistent AV interval throughout as we are delivering radio frequency current. And patient had no further inducible tachycardia, no AVNRT, no left-sided pathway any longer, no, no inducible SVT, and as a result, the procedure was completed. And this is the ECG at the end of the case. So this is an unusual case in that the patient had essentially 2, if not 3 mechanisms of tachycardia. Had a left-sided, you could say, a concealed pathway, with a left-sided antegrade conducting WPW pathway, or you could say that this was just a slanty single pathway on the left side, in addition to having atypical AVNRT. Interestingly, at the last ablation attempt, which was 5 or 6 years ago, the electrophysiologist reports that there was dual AV node physiology, but no inducible AVNRT. And for that reason, a slow pathway modification was not performed at that time. But as you can see, as the patient grew older, the AV node conduction characteristics changed, and he could have inducible SVT. So this patient essentially got 3 ablations for the price of 1. And thankfully, a couple of hours after the procedure, this is the ECG, showing no pre-excitation. An echocardiogram showed that there was no fluid around the heart, function was normal, no residual PFO from the transseptal, and the patient went home. So I thought that was an interesting case because it had a lot of different arrhythmias all in the same patient. I hope you found it of interest as well. And any questions?
Dr. Bass, in lead 2, in this EKG and even in the prior EKG, the screen just before this that you showed, what is this blip right after the QRS complex before the T wave at the end of the QRS complex?
I don't know, Perna. I think that what we have here maybe is a little bit of, I don't know. It's some kind of a repolarization abnormality. It could be related to T-wave memory from having had pre-excitation before. The computer thought it might be pericarditis. Could be pericardial irritation related to all the burning that we did. It's hard to know. It is certainly looks like, sort of looks like a little bit like ST elevation a little bit in the inferior leads here, as well as in some of the other leads, right, here and here. I actually called the patient a few days after to make sure that the patient was fine and actually felt great, and will be followed in follow-up. So, but it is an important question for sure. Any other questions? All right, well, thank you all very much. Hope you found this of interest, and I'll see you in conference in just a few minutes. Thank you all.
Thank you. Thank you.
Thank you.